Dr. Sonal Gupta, Associate Professor, Gandhi Medical College, Bhopal. Webinar hosts are Dr. Anita Borges ma'am, and to the upcoming talk. The next talk is on 4th July, and the talk is on approach of neuromuscular disorders by Dr. M.C. Sharma, Professor, AIMS. And the next light seminar is on 7th July. The topic is approach to peripheral blood smear examination by Dr. Naveen Kaka, Professor.
Begins, and I'm really happy to be trying to share whatever little that we have learned over these number of years. There are going to be 5 very simple cases, I think. Each of these have a brief clinical history, the relevant investigations, and then a set of pictures that had already been shared with the 5 participants. So they were 6 participants, sorry. So they would be describing the slides, telling me what they think it is, and then we will take it from there. The audience, feel free to ask questions, and let's try and make it interactive. So the presentation is visible, I hope.
Yes, ma'am.
Yes, Dr. Anita, it's perfect. And we have 6 students, 6.
We have 6, yeah, I made that correction, sorry, 6. So I'll start with a disclaimer too. This is not meant to be a comprehensive review. So what I'm going to try and do today is just share a few concepts to kindle your interest in CNS infections, because that's, I think, one of the most fascinating topics in neuropathology. We learn patterns, but more importantly, I think we learn what it means to a patient behind that beautiful finding that we see on a slide that makes us probably go, wow. Okay. So I've tried to make it interactive. I've tried to put in as many MCQs as possible. So just to test the system out, Dr. Gujral told me that you get only 15 seconds to answer. And I think Jansi will be doing the timekeeping. So shall we go? I have 2 test questions. There is no correct answer to this, but give me your honest answer. What do you think? A, I don't like neuropathology. It's too difficult. I love neuropathology. It's so simple. So Jansi, what is the
3
answer?
people have answered, ma'am, of which 2 answered A.
Whoa, not too good. All right. So this is test 2. Can you identify the personality in this image? Is it House? Is it Woodhouse? Or is it Tiger Shroff?
The option is B, don't know.
There was no don't know. Most of them say
A, ma'am. Predominantly are saying A.
okay, that is the correct answer. That is House. And those of you who have not watched the serial, please do so. All right, now we start. I'm going to start with a lot of fill in the blanks that I want you to do. And I'm not giving you A, B, C, D for this, so you have to fill it in. We'll start with the first one. Suppose you have a diabetic with skin infection looking like this. What do you think?
Probably fungal.
Okay. Do you want to be more specific?
An immunocompromised individual with fungal infection.
You think of fungal. Any of the others want to tell me what type of fungus? Do we have any answers from the audience?
Candida.
Yeah? Candida. Very good. Very good. Yes. And what does the audience have to say?
No answers in chat box at all.
What is happening to our audience? They're just warming up maybe. Okay, we go on to the second question. So Candida is the correct answer there. A HIV positive patient having lymphadenopathy. What's your first thought? Joshua. Tuberculosis. Very good. Exactly. I agree with that. Suppose you have a neonate, a baby with meningitis. What do you think would be the etiological agent?
Listeria.
Very good. All correct answers. I love this group. It is either H. influenzae or Listeria or Strep B. Remember B for baby. Okay. Suppose you have a diabetic with sinusitis. No marks for this. I'm sure all of you will get it right. Yes. You got my question. I think the person answering from the audience is my namesake. It says Anita. HIV positive with dermatomal rash. Again, very easy. You're supposed to see varicella zoster, but I will take that. Very simple, isn't it? Say yes. So that's how simple CNS infections are. Not CNS in general. But then let me flip it. Now, all of what I gave you were clinical scenarios where you predicted the correct infection. But how do we do it generally? We go by pathological patterns, isn't it? That's how we approach any particular infection. So suppose you have a slide full of this. What do you think is the pattern? Whoops, sorry. Yeah, you have 3 choices. Do you think it's suppurative, granulomatous, or lymphohistiocytic? A, B, or C?
C. Many group in chat they've answered C.
C. Okay. And what do my group online tell?
A, ma'am.
A, suppurative. Very good, because you're seeing a lot of polymorphs out here. So this is suppurative or purulent. Excellent. But the question doesn't stop there. The second question is, if you think it is suppurative, what is the most likely organic? Very simple.
Fungal.
How many of you think fungal?
Fungal.
Fungal.
Chat is full of A.
Bacterial. Chat is full of bacteria. Okay. And online we have some saying fungal. Who said that? Come on, Ona. I'll give you double marks.
Bacterial.
Bacterial, I agree, but fungal too. You have to remember that fungal can also produce this kind of a suppurative pattern of inflammation. Any particular fungus you want to tell me? Not all fungi are going to give you this kind of a purulent. Candida. Very good. Excellent. So any yeast form, remember, is likely to be purulent, suppurative, and most commonly candida. Last question. Why do you have a suppurative or a purulent response with bacteria and fungi? So what is common to yeast forms, bacteria, which give you this kind of a suppurative input? What's the basis for it? Very simple. It's just that remember these are called microphages. So anything which is small enough to be engulfed and capsulated will always generate a suppurative polymorph-rich response. Okay. All right. Here's your favorite. Same questions again. What's the pattern? Is it suppurative? Is it granulomatous? Granulomatous. Very good. Likely organism. I don't even need to give you 5 seconds. Yes. What is the likely organism?
Could be bacterial.
That may be bacterial or fungal.
Bacterial or fungal. You want to subclassify the bacterial and fungal?
Bacteria.
Mycobacterium. Obviously, very good. And hyphal forms of fungi, right? Like the yeast forms that you saw. So it cannot be protozoal or viral. But again, same question again. Why? What is common to bacteria and mycobacteria and hyphae, which produce this kind of granulomas?
Cell wall.
A very, very thick cell wall with the fungal hyphae, which essentially makes it indigestible. So all of your army of histiocytes are going to try and come together to engulf it and try to destroy it. Okay. Or like AFB, those are obligate intracellular that also can produce a granulomatous response. Clear so far? The last pattern slide. What is this pattern? By elimination, you're going to tell me? Lymphohistiocytic. But what's the likely organism here?
Virus.
Viral.
Is it because of this insect that you're looking at here? You are saying so?
Chat C.
Chat to see, very good. And online, I'm getting what? Viral. So both are correct. It's either protozoal or it is viral. So the protozoal that you're looking at here is actually a cyst of toxoplasma. You can also get it with amoeba. And with viruses, more commonly with HSV, CMV, etc., you get a lymphohistiocytic. Last question again, my favorite. Why that kind of a pattern? Because all viruses are obligate intracellular and so are protozoa. All right, so far? So basically why I put these two out is that you need clues to diagnose CNS infections. What are the clues? The clinical prototype is very, very important. That's what we saw in the first set of MCQs. And this is what produces a very classical pathological response, a stereotypic pathological response, which is what you use to diagnose the next few slides, correct? And this is what leads to pathogen identification. So what is it that is dictating this stereotypic clinical prototype, this very classical pathological response? Any answers? Answer is very simple, and that is the immune systems. Okay? So this entire pattern that you're looking at is all thanks to your immune response to various pathogens, and each type of immune cell is geared to tackle one type of pathogen. So we learn that as we go along with the 5 cases that we have put up today. Right? Now, before we do that, I want you to remember that nothing is possible without clinical interpretation. And even the few liner history that I've given you, please ensure that you try and identify what the clinical diagnosis that can be. So just to help you out with the clinical, remember that the brain is very, very simple structure. You have coverings, which is called the meninges, and then you have the parenchyma itself. Now, the infection can either infect the meninges or this parenchyma. The parenchyma is, we call it gray and white matter. The gray matter is also called encephalon, which in Latin just means gray. So it might involve only the gray matter when we use the term encephalitis. It can also involve both the meninges and the encephalon when we term that meningoencephalitis. Is that clear? It may go deep into the parenchyma and produce mass lesions. Now, clinically, how do clinicians go about trying to differentiate these? Because the pathogens that affect each of these levels of neuraxis is going to be very different. Okay, so that is level 1 of trying to diagnose. So clinicians suspect meningitis whenever there is a triad of fever, headache, vomiting. Now, remember, this is common to any form of CNS infection. It just means there is cerebral edema. It means there is raised ICT. But the pointers that you look for in an infection is if you find neck stiffness, that is prototypic of meningitis. If you find presence of seizures in the patient, then that tells you that the gray matter is involved, because very simply that's where the neurons are. Anything irritating the neurons will produce seizures. Now, if there is neck stiffness with seizures, it's obviously a meningoencephalitis. And if it is going deep-seated to produce, let's say, an abscess or a granuloma, in addition to all of this, you will get focal deficits. It could be a stroke, it could be various kinds of deficits, which is dictated by the site of the lesion. Okay, so far? So very simply, 4 prototypic, you can remember: meningitis, which will have neck stiffness; encephalitis, which will be present with seizures; meningoencephalitis will have both; and any mass lesion deep in the parenchyma will have focal neurological deficits. So shall we go on to case 1? And I think it is Saurabh.
Yes, ma'am.
In true style of military, you go first. So here is a
Thank you.
25-year-old man, an agricultural laborer, came with fever, headache, 2 weeks, altered sensorium 1 day, had left hemiparesis on examination. An MRI was performed and the lesion was removed. So what are your thoughts, first of all, Saurabh, on the history?
Ma'am, according to history, patient has fever and headache. So our first diagnosis goes towards brain abscess.
One more point to say it is an abscess. Just to
Ma'am,
repeat, fever, headache,
fever.
only case. There is swelling of the brain because of an infection.
altered sensorium
that's
since
right.
1 day.
which again tells you it is brain swelling. Priyanka, you're going to be the last word for us, right? The next line, just read the next line.
Deficits are
And
there.
there's deficit is there.
Deficits
Isn't it? So we said if there is parenchymal involvement, Saurabh, there will be
Yeah.
deficit. So
Deficit.
clinically, you are thinking what you thought was very correct and what you said was
Abscess.
probably an abscess.
Abscess.
So what would the clinician ask for if he makes a diagnosis of a parenchymal lesion? He's going to ask for an
MRI.
MRI, correct, which has been done. So I'm going to show you an MRI next. And you can, I know you had a very brief
There is
class
a,
of MRI. Do you want to try?
yes, ma'am.
Go ahead.
There is a space occupying lesion,
Very good.
actually a ring enhancing lesion with
Excellent.
central cavitating or necrosis, I guess. And
Yes.
there is a midline shift also because of the lesion, space occupying lesion. Some edema is also there, ma'am, I guess. And the lesion is in temporoparietal right cerebral hemisphere.
Okay. Okay. You get almost 99% marks. Excellent. I'm so happy that you attempted. And for all pathologists, please learn to read images. Okay. So what he said was absolutely right. What you're looking at is the two hemispheres. This side you can very nicely see it's massively enlarged. So Saurav said that there is a shift in the midline. So this is what is the midline, and you can see it is shifted. This white line means that there is contrast enhancement, and it's like a ring, and that's why he used the term ring enhancing lesion. The center is jet black. So on a contrast, if the center is black, it just means it's a cavity. Like he said, there is necrosis in the center. There is no tissue. There's tissue death there. And this enhancement just means that there's going to be a lot of blood vessels out there. In an infection, to us, it means that we're going to be seeing granulation tissue, right? And outer to that, this lighter black that you're seeing, almost gray, not as gray as this, but you can see this. This is massive perilesional edema. So absolutely right. It's a ring enhancing lesion, likely to be an abscess. Saurabh, do you want to tell me what are the layers of an abscess? Any abscess. This is a surgical question. How do we define an abscess?
Ma'am, there is actually a cavity
Correct. Filled with?
mostly filled with granular or necrotic material.
Perfect. Very good. So that's what an abscess is. So this was the lesion that was excised. Okay. So that's the, you want to describe it. Sorry, all yours.
Ma'am, well circumscribed
Mhm.
cavitating lesion
Mhm.
with granular and some necrotic material inside the cavity.
By that you mean this one?
Yes, ma'am.
Okay.
And on right side, we see the
Wait, before you
scanner
jump
view.
to this,
Okay,
before you
okay.
jump, grossing is the most critical. First is clinical, second is grossing. Does anyone want to add anything to the gross description? Anybody? Brown colored cavity. Yeah, say some louder. I didn't get that. Brown colored cavity. It's a little brown. Very good. Who said that? I'm sorry, I can't see the names. Who said that? Supriya? Bang on. Okay, we'll come back to that. Yes, sir. Go ahead. So it's a cavity, you said, as granular, little brownish,
Brown
and it has a
color.
very nice wall around it.
Thick
So
wall.
what is the histology showing?
Ma'am, this is the scanner view showing the cyst wall is lined by eosinophilic material.
Okay. This one you're talking about, the wall.
Ma'am.
Okay. Do you want me to go to the next higher magnification?
Yes, ma'am.
All right, here you are. So that's again the center, and that's the wall. What are you seeing in the center?
Ma'am, we can see the multiple necrotizing granulomas are there, ma'am.
Correct. So what kind of necrosis is this? You think it's, there are only two types, it's coagulative or it's liquefactive?
Ma'am, it's more of a coagulative. Sorry, it's liquefactive, I guess.
Chat also liquefactive.
Very good. And see, coagulative typically is what you see in caseous necrosis, very compact.
In case yes.
Yeah, so this is more liquefactive because you have a lot of spaces in between, which is telling you that it is getting liquefied. Very good. So you have liquefactive necrosis, and you want to see the cell type? I'll show you the next slide. What do you think?
Ma'am.
So this is in the wall. You saw the center first. Now you're looking at the wall.
Ma'am.
Go ahead, sir. Describe.
Ma'am, multiple giant cells.
Very good.
You are foreign body type giant cells.
Yes. And so you think this is foreign body? Why do you say it's a foreign body giant cell?
Ma'am, pattern is like cells aggregates are diffused, not like Langerhans periphery. The pattern is
very good. It's clustering together.
Clustering.
Haphazardly arranged. It's kind of grouping together the nuclei. What about this one? What about this one? Yeah, I agree. I think in the audience they are saying that there are a few.
Yes.
There are some Langerhans kind of giant cells. Yes, somebody said.
Yes.
So what are other cell types, or don't you want to know? Is it not important?
Ma'am, there are normal brain parenchyma, astrocytes can be seen.
Okay. No, but what are the other
Lymphocytic
cell types?
Yes,
Lymphocytes.
mononuclear infiltrates, yes, ma'am. Predominantly lymphocytes are there.
Okay. Are there any other cell types that you would like to look for? In other words, you are saying it's a granulomatous response.
Fungal.
How do you go about?
Ma'am,
What is your approach to?
Ma'am, in the previous slide, there were few fungal hyphae were there, ma'am. The right one above.
Out here,
There are, ma'am, few septate fungal hyphae.
there are a few septate fungal hyphae. Very good. And where do you want to look for hyphae? In which cells?
And they are invading the
Microcytes.
Correct. And particularly within giant cells, right?
Giant cells.
So is there anything within the giant cells that give you a clue that there might be fungus? What are the clues that you use? I want at least 3 clues.
histiocyte.
Histiocytes would be common to any necrotism. Because to mop up the necrosis, you'll get histiocytes, macrophages coming in to mop up all of that debris.
Type
Is
of
there
giant cell.
Type of giant cell, very good. Yes. What type would tell you that it is likely to be fungal?
It should be not foreign body giant cell. It should be
Foreign body
non-caseating
giant
granuloma. It should be not.
Excellent. I wouldn't say that. You can get both caseating as well as non-caseating. So that doesn't help us to differentiate. I agree with foreign body giant cells. Anything else? In fact, if you see a lot of foreign body giant cells, it should up your antenna to say, search for giant cells. Search
Negative
for
shadows.
In chat, there is an answer, negative shadows.
Very good. Yeah, these, can you see some empty looking structures here? You can see it here also. So this kind of negative stained structure should also make you think that there is fungus. Anything else? I want one more. At
In
least
chat, vacuoles is mentioned.
vacuoles, negative staining, I would put that together
Special stain.
before special stains. Come on, you're all pathologists. Are they going to come to you with special stains? No. I can see. In fact, I've put here what cell type. What? It is a big clue. In fact, I think you can see some eosinophils. Absolutely right. Eosinophils. Very, very important clue. So if you see foreign body giant cells, if you see eosinophils, and you see these kind of negatively stained structures within the giant cells, think fungal. Right? So you'll have to answer these 3 questions before you go further. I think you've already said it. Clinically, you said abscess. The host response you said is
Granulomatous.
granulomatous and necrotizing.
Yes, necrotized.
So your possibilities, you did not even have differentials, Saurabh. You said only fungal. So next, what do you want?
Special
stains. Ma'am, I would like
You
to
want
do
special stains.
special stains.
Okay.
Pass
Next
Mason's font. Ma'am,
Okay.
PS Mason Fontana stain.
GMS, no.
G.
Okay. Mason
You
Fontana
can do.
for what?
Ma'am, to see the pigmentation, like it's
Okay,
melanin
very good.
pigmentation.
Excellent. And one more.
GMS, no.
GMS. Well,
GMS
means
we can do.
I think if these 3, but none of you think it could be TB at all. No? You're all very certain it's fungal.
Ma'am,
You
we
can
could
get more
do
than one infection.
J-
Don't forget AF. You should do a ZN stain for
Yes,
it.
ma'am.
There are always surprises. Okay. So just before we go that, I've just picked some crazy looking pictures for us to, I think all of you are experts on granulomatous, so we can quickly recap. All right. So the causes, we could divide it basically into 4 infectious, a foreign body, autoimmune, and unknown causes, right? Which includes your favorite sarcoidosis. Don't forget malignancy also. So you are going with infectious, so it could still be mycobacterial, fungal, or parasitic. Now, I found these very pretty pictures. I put the source out here, so any if you want to, can look at it. So the components, you're all very familiar of a granuloma. You can have a necrotic center. You'll have your epithelioid cells, which you see a slipper-shaped nuclei, which will cluster around the central necrotic zone. These fuse together to form giant cells, and then you'll have a lymphocytic cuff. Now, we know that there are several types of granulomas. So you're going to tell me, I'm going to put up a picture, and you're going to tell me which is what. We can start with the first one.
Caseating necrosis,
It's a
tubercular.
caseating granuloma. Very good. And what is this one? Here in the center, you're seeing a lot of polymorphs, right? But in addition, you are seeing a few giant cells. You're seeing epithelioid cells. You're seeing a cluster of lymphocytes. So what kind of a granuloma is this? Anything on chat?
Liquefactive in chat.
Liquefactive is a type of necrosis. What we are talking about is not the necrosis, but within this beautiful granuloma, you are seeing polymorphs in the center. So give it a name. You can make up a name. When you
In
see
chat,
polymorphs,
suppurative.
suppurative granuloma. Excellent. So this is a suppurative granuloma. It's important for you to identify these because each of it is going to give you a clue as to the pathogen. Correct? Now, what about this?
Donut.
There's a very typical giant cells out here.
Teuton giant cell.
Teuton giant
Teuton
cells.
giant cell.
So what kind of a granuloma is this?
Xanthogranuloma.
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 Excellent. Very good. And what about this? You're having necrosis, and then you have these epithelioid cells which are standing like soldiers. It's standing. It's like a fence. That's a palisading granulomas. Excellent. And what is this? All of the giant cells here you can see are clustered together. It's foreign body granuloma. Very good. You should identify this. And this one, of course, it's even labeled here. Caseating granuloma. So this is a typical sarcoid granuloma.
Sarcoidosis.
So if you have a caseating granuloma, what are your differentials?
Tuberculosis.
Tuberculosis.
Second.
Maybe fungal also.
Not maybe. Fungal also. Second. So in fact, some people will say first TB, second TB, third TB, and then come to fungal because we are in India, right? So caseating granuloma, TB versus fungal. And this very typically has this, keep this architecture in mind. Yeah? Center necrosis, then you'll have your epithelioid cells which are surrounding it. You have giant cells which are scattered around, usually in the periphery. But contrast that with the foreign body granulomas. where you'll have aggregating of these giant cells within the center. You see that change in the architecture? That should give you a clue to fungal because you cannot afford to miss fungal. You just can't afford to miss. You know why? What will happen if we do miss? What will happen? Doesn't matter.
Disseminated TB.
It kills the patient if they are not treated. As simple as that. Untreated fungal kills. So you have to. That is why any granuloma, you should always do your PAS, GMS, and AFP together. All right. So please keep that in mind. So this is a foreign body granuloma. And if it's foreign body granuloma, what all will you think of? Very quickly.
Sutures, talc.
Yeah, any foreign body, but also fungal. Put that first. Okay. They very typically have this kind of a granuloma with a lot of foreign body giants. What about suppurate?
Cat scratch.
Okay. Yeah, by the book Cat Scratch, but honestly, have any of us ever seen one? I don't know. Maybe some of you would have seen. I don't know if Dr. N.C. Sharma has seen, but put that lower down on the list. What is more probable? I'll give you 2 seconds to answer. If you don't, I'm moving to xanthogranum.
Chat, it is actinomycosis.
Excellent. Full marks. Yes, actinomycosis is very important. And if you see a suppurated, first thing to come to mind has to be actinomycosis. What about your this very pretty xanthogranum? Yes. Hey, come on. When does these xanthoma cells form? Something which is very lipid rich, isn't it? So what can it be?
Can be seen in xanthogranulomatous polycystitis.
Very good. Excellent. And the other? Anything in the fat necrosis? Something. Very good. Anything else? With your Teuton giant cells? Renal. Yeah, okay, Priya. What renal?
Xanthogranulomatous pyelonephritis.
Xanthogranulomatous pyelonephritis. Yes. Yeah, we can go on and on. So, Malakoplaque. Okay, okay. Let's continue. Very good. We got several answers right. What about a palisading granuloma? This is also one granuloma you should be able to recognize.
Rheumatoid.
Rheumatoid, very good. Anything else? Rheumatoid is an excellent answer. Anything else? Parasitic. Okay, don't forget parasitic. But invariably, particularly in the CNS, if we see a palisading granuloma, we think parasitic, like cysticercus or any other parasite. Another thing which can have this kind of palisaded is also a TB abscess, where the immune response is degenerating because of immune suppression. Okay, foreign body, you told me sarcoid. We'll move on. So I found some very pretty pictures of giant cells for a very quick recap. So that's your horseshoe, which can be in one pole or both poles. This is your foreign body. This is the Teuton. Of course, tumor giant cells. I don't like tumors, so we won't go into it. But when you have this combination of, what is this? Foreign body giant cells with eosinophils. Your diagnosis should be
Fungal.
fungal. Right, fungal first. So you've already told me what you want for a diagnosis, and I think you already discussed what it means for the patient. So this is what the PAS is showing. Sort of describe.
PAS is showing multiple septate fungal hyphae. Few are branched.
Very good.
Few are
What kind of branching?
swelled.
Acute angle branching.
Good. Okay, so septate, yes. Branching, yes. Acute angle, yes. And then?
Pigmented, ma'am.
Brown pigment,
They are
yes.
pigmented, brown pigment.
They have a brown pigment. In fact, even on the HND stain, you could see the brown pigment. And if you remember the gross, that was Supriya, right? Yes, you said brown? Brown color. Very important to recognize that. Okay, so that itself should give you a clue, particularly because this pigmented hyphae we can pick up on HG. And we just come to this type of fungus. They don't have a very good prognosis at all. Okay, many of them die eventually, even after surgical excision and treatment. It keeps recurring and they tend to die. So, what is your diagnosis, sir?
My diagnosis is pheohypomycosis. Okay. And differential is aspergillus, maybe.
Why did you say aspergillus? It's a very good differential because aspergillus also will have this kind of
Septate hyphae.
septate, acute angle branching. But what is unusual for your aspergillus is
pigmentation and
pigmentation.
mold.
Yes, and one more. And of course, aspergillus can show pigment, but generally we pick that up on a Fontana Mason stain. Having a HND showing pigmented fungal hyphae is very unusual. But there is one more feature that will help you, and that is, can you see these rounded brownish structures?
Sclerotic bodies.
Yeah, they're called sclerotic bodies. They're also fancifully called copper pennies. Don't they really look like copper pennies? So that's a very, very distinctive feature of pheohypomycosis. And the reason it happens is because these septae, they are very, very tight septae. In fact, we call them disjunctures. Okay, and they constrict it so much that it disconnects from each other and it can get rounded up to form these kind of sclerotic bodies, or what are called as copper pennies. They're very beautifully seen. Okay? That is something that you never see in your aspergillus. Is that clear? So acute angle septate, branching, pigmented fungal hyphae with copper pennies, pheohypomycosis is an excellent diagnosis, but there should always be a last line that you add in your reports. And what is that?
Savory.
Information we can do molecular testing, PCR.
before molecular? Molecular may not be
Culture.
available. And keep in mind, Saurabh, that actually speaking, molecular is available only for aspergillus.
Yeah.
The probes are specific only for aspergillus. They don't have, at least most places don't have the probes for pheohypho. They don't even have it for mucor. Okay? So always put that culture confirmation required for, yes, always. So you should only say that it morphologically resembles pheohyphomycosis.
Right.
Fungal abscess morphologically resembling pheohyphomycosis. Culture confirmation advised. So if you do a culture, this is very, very typical. Can you see this olivaceous colonies?
Yeah.
They're black olivaceous colonies. And this particular case was cladosporium, which is one of the types of pheohyphomycosis, which causes CNS infection. And in this lactophenol cotton blue mound, you can see those ellipsoid conidia, which form chains, which is very typical of pheohypho, particularly cladosporium. Is that clear? So that is the diagnosis, pheohyphomycosis. They used to call it chromoblastomycosis, pheohyphos, correct? Just a very quick recap. We know that it is actually a saprophytic fungus and it's found in soil or decaying vegetation. It is common to both Africa and India. And these are patients who are not immune compromised. If you remember your clinical again, this was a 25-year-old. And what was occupation? Agriculturist. So that's a clue that, yeah, that's a very important clue. So this patient also was an agriculturist. It can also happen in anyone who walks barefoot on soil which has pheohyphomycosis spores. Okay? And very strangely, this fungus likes the brain. It doesn't affect any other organ. It likes only two things. It likes the skin and it likes the brain. Can you tell me why? Anybody wants to guess?
Traumatic implantation.
It's going into skin. So yeah, skin gets involved.
Lymphatic.
But there are no lymphatics in the brain. So why does it come to brain? It comes into brain through hematogenous spread. No, it goes into blood. It can choose any organ in the body. Why should it choose only brain?
You mentioned glucose, cool areas.
No. Hey, brain is pretty hot here. It is a greedy organ. It takes 20% of the blood supply from the heart.
High oxygen content.
That is there even in the lung. Why doesn't it go to the lung? Come on, quick.
Immune response to
Particularly because remember this is an immune competent host that you get this.
immune shield itself from the immunity attack of the immunity. So
You want a clue? Yes. Okay. What's the color?
Brown.
Why is it brown?
melanin.
Melanin, right.
Wait. I've not completed my question. Where is melanin formed from? The biochemical pathway? Melanin is synthesized from? Forgotten, huh?
Melanin
I did biochemistry decades
Melanin
ago.
is tyrosine.
hormone from the
Dopamine, isn't it? Dopamine. That's what goes into your melanin synthetic pathway. So where is dopamine found? Even if you don't know, the fungus knows. Where?
brain.
Isn't it? It's a neurotransmitter found only in the brain.
Brain.
It's also found skin because it has melanin. So it has to home to whichever organ has melanin, because is melanin good or bad? I'm going to ask crazy
Melanin
questions.
is good.
Melanin is good, exactly. It is very good. Okay, because if you remember, it's one of the most important immune defense mechanisms. Correct. So what does it do? It has antioxidant property. So any oxidative burst, which is the final pathway for any kind of immune response and injury, is an oxidative burst. So it prevents that. So that's why it coats itself with melanin pigment. Smart fellow, no? Actually, every bug is smarter than us. It knows immunology, it knows chemistry, it knows brain anatomy, and believe me, it also knows how to, it knows therapy also. We'll come to that very soon. So when it does come into the brain, it can do two things. Because these are large fungal hyphae, they block blood vessels and they can produce these kind of nasty infarcts, or they may produce these kind of, like we saw, an abscess. Okay? Speciation, like we already said, requires culture, and you have several different species. The most common that we have seen has been Fonseca pedrosi and Cladophylophora, or what we saw here, Cladosporium. Now, Fonseca actually causes calcification of the fungal hyphae. So whatever Fonseca we have seen, interestingly, have been ring-enhancing lesions calcified, and they've been mistaken for ganglioblast because it occurs in the young, right? And they're calcified lesions. So to summarize, if you have a brownish color in the wall of an abscess, if even on HE you're going to see thin pigmented hyphae, and they have very prominent disjunctures and copper pins, culture olivaceous black, your lactophenol cotton blue will show ellipsoid conidia chains. The diagnosis will be pheohyphomycosis. Clear? Any questions on this? If no, we'll very quickly go through the other neurotropic fungi. We have yeasts, we have pseudohyphae, and we have branching hyphae. They're only of three types. The yeasts are most commonly we see Cryptococcus and Candida. Just to complete the list, of course, I'm telling you histoplasma, blastomyces, coccidioidomycosis, and paracoccidioidom. I have never seen any of these except one case of histoplasma during the HIV epidemic. Again, not in the brain, but in the lymph node. Okay, so we've only seen Crypto and Candida. The pseudohyphae, Candida is the most common. Branching, we have Aspergillus, Zygo, and Pheohyphomycosis. Now remember that the fungi are very, very clever. We spoke about Pheohypho, which uses melanin to protect itself. But basically, all fungi use one thing to protect itself from our whole immune response, and that is the capsule. What does that capsule do? You use that capsule and cell wall to stain it, whether it is your methanoline silver, whether it is your periodic acid skiff. All of that is staining either the capsule or the cell. But remember that in addition, these have antiphagocytic potential. If you remember the cryptococcus, we talk about that very thick polysaccharide-rich mucinous capsule. It is also very pretty to look at, but it protects that fungus from immune response. So it actually inhibits immune response itself, which also means that if you look at CSF in these patients, there are no inflammatory cells. Okay, so the patient will come with severe bursting headache. The clinician will think it's raised intracranial tension. You take out CSF, protein will be high, but CSF cell count will be very, very low. It comes out at a high pressure. Okay, so it has three parts. The capsule, you have a mannan, you have glucan and chitin. You need to remember this because this is the basis for all of the immunological tests that are there. Like, for instance, you have a glucan, beta D glucan testing. You have the mannan testing for aspergillus. All of this is components of the cell wall. So it's a very, very important anatomy of the fungus which protects it from our immune system. But what does it cause in the brain? What is the pathology is all dictated by the size of the fungus. It is as simple as that. So if you take the smallest, which are the yeasts, all of them, when they come in through blood, it is going to go to the smallest blood vessels and get stuck. Correct? Now, these smallest blood vessels are what you see on the surface of the brain. And therefore, the pathology it will cause is, it infects the surface of the brain, and therefore it causes what? Saurabh? Meningitis, no encephalon. It's only meningitis. It causes encephalon only if it goes into the parenchyma. Right? So cryptococcus, classic example of a yeast, it is going to cause a meningitis. Is that clear? But your candida are smaller than cryptococci, so they can even enter into the parenchymal blood vessels, and they produce micro abscesses. So they were present with
Encephalitis.
encephalitis. Very good. See, CNS is so simple, isn't it? Okay, so it either presents with meningitis or micro abscesses, and that's what yeasts produce. Now, if you look at hyphae, they're going to block larger blood vessels. So because of that, they can either produce granulomas, which is what you see in aspergillus, or it may produce infarcts because of angioinvasion, which is what you see in zygomycosis. Remember, aspergillus can also produce infarcts. Is that clear? So very simple. Yeasts produce microabscesses, cryptococci, meningitis. Large hyphal forms produce either granulomas or infarcts. So this is a classical example of cryptococcal meningitis. And you can see the entire brain is covered with a beautiful glistening exudate, gelatinous exudate. In fact, when you take it in your hand at autopsy, it slips through your hand. And that is diagnostic of cryptococcus. If you take a histological section, this is what you see. Can you see this is the subarachnoid space? And you can see numerous, can you see these rounded yeast forms? You can also see that some of them are budding. Can you see that? So this is cryptococci. But to confirm it, of course, we can do, what is this name? Yeah. And this is a PA stain actually. This is mucicarni. And you can see the beautiful magenta colored yeast. And here you can see that they are enclosed within giant cells. Here they are free. So remember, the immune response is going to dictate the host response. So if the immune response is good, you will get a foreign body giant cell response. You will get cryptococci within that, forming a beautiful granuloma. And that will produce a mass lesion, which we call as a cryptococcoma. Very, very rare, because we hardly ever see cryptococcomas in the immune competent in India. What we more often see is this kind of immunodeficient host, like the HIV patients, where no giant cells, because there is no cell response, and you'll have numerous extracellular cryptococci, which are just flooding the CSF space. Everybody's happy because the microbiologist culture will be 100%. India 100%. Why? Because they're all floating freely in CSF. Okay, so it's easy to diagnose. But if you have cryptococcomas, the CSF yield may not be good, and that is why the host response is very important for you. It is dictating the biology of the infection. Okay. Now, ecologically, we know that cryptococci can be of two serover. It could be either a var neoformans, which is more common in the immunocompromised, and the var gatti in the immunocompetent. This var gatti is what you usually see in the bark of the eucalyptus trees. Okay? And although we have eucalyptus in India, actually our microbiologists did that. They went scraping all the eucalyptus trees and they didn't find cryptococci. So maybe that is why epidemiologically we don't see var gatti so frequently. Okay? But we do see var neoformans, and that is usually found in pigeon droppings. Also other birds like parrots, canaries droppings can have, but more frequent in the pigeon droppings. So I already told you its most important virulent factor is the capsule, which is a negative charge, and it inhibits phagocytosis. It inhibits complement activation. It actually enhances HIV replication. Again, this also interestingly makes melanin, and that is why, if you think about it, it homes to the brain. So in culture, if you look at cryptococcus, it is actually brownish black colonies. You actually have to add dopa to the culture media, then only it grows. So it homes to the brain, it makes melanin, and it protects itself. And that's why if you look at our brain, we'll find lesions most commonly in the basal ganglia and substantia nigra. I don't know if you knew, basal ganglia is dopaminergic. And if you didn't know, cryptococcus knows it. So it homes to those sites. Is that clear? So this is mucicarni, this is PAS, and then methylamine silva. So remember, mucicarni picks up the capsule, whereas your PAS and the methylamine silva picks up the cell wall. Is that clear? So those are the three stains that we do. The other dimorphic fungi, you can differentiate it based on the type of budding and the slits. So if you look at histoplasma, they have very narrow slits. If you look at blastomyces, they have a very wide gap between the yeast forms. The coccidioidomycosis typically has spherules with bursting out endospores like this. Penicilliosis has this kind of a split across the yeast forms. So these are all morphological, but the final has to be with the type of culture characteristics that you see. The hyphal forms very quickly. Aspergillus is ubiquitous. It is there everywhere in soil, water, decaying vegetations. You have several subtypes, flavors, fumigators. Those are the two most common in the CNS. The brain gets affected either through hematogenous spread or local spread. And that is why if there is sinus involvement, we always suspect aspergillus because of local contiguous spread. So when there is contiguous spread, what it produces is an aspergilloma. It means there is a granuloma. It means you have your foreign body giant cells within which you have the fungal hyphae. And this tells you that the host is immunocompetent. Okay. But if you look at the immunocompromised host, again, it's the same thing. No granulomas, no giant cells. It will just diffusely invade the brain. And that we term as invasive aspergillosis. So remember that characteristic host response we are talking about, which we use to diagnose, is seen very typically only in the immunocompetent hosts. So this is what you see. Again, a beautiful foreign body granuloma. You can see the clustering of the giant cells. Unlike TB, where you have peripheral based giant cells, here they all come to the center. If you see carefully, there will be eosinophils too. Another feature very common in aspergilloma is fibrosis, very dense fibrosis, because the immune response is actually trying to wall it up. And in fact, when the surgeon goes in and excises that aspergilloma, they better be careful because they are opening up all tissue planes. And if we delay diagnosis of fungal, the patient invariably comes to you for autopsy because they develop actual true mycotic aneurysms, subarachnoid hemorrhage, and bleed because the fungus is just on a wild rampage because that entire beautiful fibrous capsule has been beautifully excised by the surgeon. So remember, whenever you get an intraoperative squash and you see giant cells, do a quick PS. We have time and again make that mistake of seeing giant cells, feeling happy that it's TB and saying TB. Surgeon comes out, 2 days later the patient develops bleed, and then we realize that it is fungal because after 48 hours we would have got our sections. So we go by location. If it is basic temporal, if it is basic frontal, if it is close to sinus, even the clinicians are very alert. If we say it's granulomatous, they just instill amphotericin into the cavity and come out. It doesn't harm. So they would rather do that than wait for us to, after 2 days, when it's too late, say fungal. So this is a GMS with acute septate branching fungal hyphae, and this is the beautiful greenish colonies that you see on culture. There are several non-culture methods like Saurabh was talking about. One is PCR, but the other is the galactomannan. Very, very sensitive. But just keep in mind that it is so sensitive, it can even precede imaging findings, can precede clinical symptoms, and even culture by 5 days. So very often when you do this test and the clinician doesn't find anything, he will tell you it's false positive. It is not. Wait and watch. In 5 days, they will develop symptoms. But keep in mind, if the patient is on beta-lactam antibiotics, you can definitely get a false positive. Any fungal test that you're doing, which is non-invasive, other than biopsy, please keep in mind that it should not be interpreted without clinical context. Okay? It can make mistakes. So zygomycosis, we know the predisposing factors. In addition to diabetic ketoacidosis, remember there are several other things. It can be in patients with renal failure, on desferrioxamine therapy, starvation, neutropenia. What is common to all of this, interestingly, is just one thing. There is acidosis. Be it metabolic acidosis, be it respiratory acidosis, whatever it is acidosis. And what acidosis does is it releases free iron. And that is what your fungus wants, which is normally sitting in our sinuses. And it's just not, it's called that the brain came in its way. It is just going through that sinus and trying to get at the free iron, which is there in the blood vessels, which are at the bottom of the brain. Is that clear? So there are different clinical forms. You have rhinocerebral, which is the most frequent that we see in the CNS. It also has the highest mortality. Right? We saw lots of it during the COVID epidemic. Histologically, it will show you, unlike your aspergillus, this won't have a granulomatous response. This will not have your giant cell because it's an acute process. Okay? What it will have instead is sheets and sheets of polymers. What should give you a clue is if you find this kind of fibrin coming out, leaching out of vessels, your antenna should go up. And that is where you look for it. And can you see these bluish hyphae which is there? This is just a H&D stain. Of course, if you do a GMS, you'll have your beautiful aseptate, broad branching hyphae, which is, this is a blood vessel, and you can actually see it invading the vessel. So that's a quick recap on fungus. Should we go on to case 2?
There is one question in chat box. Is there any difference between pheohypomycosis and chromoblastomycosis?
No, ma. It's essentially the same. The correct terminology to use is pheohypomycosis. Earlier, they used to call the same thing as chromoblastomycosis. So they stopped using it because it scared people, because the term blasto was used. They used to think it's a tumor. So the correct mycological term now is pheohypomycosis. But of course, the subspeciation is entirely cultured. Any other questions?
Nothing. No. Dr. MC Sarma, sir, do you want to add any points to this case?
Excellent, Anita. It's more than enough. But
More than sir.
One or two things. One is for the cryptococcus. I think if you do the combination of PS and AB pass, Elchin blue, it's a good contrast. Secondly, I think most of the time xanthogranulomatous term is a misnomer. They are not actually granulomas.
Correct.
Many places it is used in pathology.
Yeah.
But definition of granuloma is a collection of organized
Epithelial, yes.
epithelial cells of the modified macrophages. But anyway, that's a. The other is many times you have taught the pattern, very important. Even I realize this is very, very important for the diagnosis. But we are not able to pinpoint the etiology. So I think culture is very, very important to correlate, especially in the pyogenic.
Absolutely. Absolutely. And even the granulomatous, very often, I think the surgeons forget to send for culture.
Yeah.
So important for the students, when you see a granulomatous, please tell them to send for culture. But worst case scenario, if they have not sent, Saurabh mentioned that we can do PCR. Remember, you can extract DNA even from paraffin blocks and send it for PCR testing. Okay, so keep that in mind. And sir made 2 very important points, so you'll have to bear that in mind.
one more ethical. It's
Yes, sir.
many times we are getting the cotton or the gauze because previous surgery there are a lot of bleeding, so people put on for the and after some time there is foreign for you. You told that foreign body granulomatous reaction. Should we mention in the report?
So I think we would call it a gossipy bioma. That's the term used. And it's an ethical question, yes. Because what we have found is when we use it within our institute, it's okay. But we get a lot of reference from outside, and the clinician always calls up and says, "Hey, can you avoid using that because the patient thinks that we left something behind there, and because of that there is a granuloma." So if it doesn't really add to a diagnosis, so maybe in the description we can write it. But leave it. That's what we follow.
Thank you. Thank you. Can we go to the next case?
Yes, yes. So case 2 is Janki Raman, right?
Yes, ma'am.
Yes, Janki, all yours.
28-year-old male presented with weakness, both lower limbs, with stiffness for 1 month. Examination, spastic paralysis.
Paraparesis.
Paralysis. Sorry, ma'am.
Paraparesis.
Paralysis, yes, ma'am.
Which means both.
And
two
MRI
limbs
showed
are-
T1, T3 lesion.
Okay. So clinically, you would localize it to the
Ma'am, it's a space occupying kind of lesion, ma'am.
very good. In the spinal cords. The term we use because we know this is an infection. So the term we use is a
Myelin.
okay. So I don't have the MRI of this particular case because it came to us from outside, but this is the histology. Yes, Janki, I think it's a very simple case.
Ma'am, I could see lamellated eosinophilic acellular areas.
Hey, don't jump into that. This is to all students. When you're describing, start first at a very low level. What kind of pathology is it? Is it an abscess? Is it a granuloma? What is it? And when you have the entire slide, I'm sorry, I couldn't give you a digitized slide. When you have the entire slide, please start with what is the tissue you're looking at? Is it brain parenchyma? Is it cord tissue? Is it extradural? Is it soft tissue? Are you looking at ligament? What are we looking at is something that you should first tell. And that really helps sometimes because if there is a mix-up, it helps you to know that this doesn't belong to that patient. So please start with the main pathology. Then you come to a closer. So yes, Janki. What do you
It's a granulomatous type of reaction, ma'am, with multiple multinucleate giant cells.
Yes. You want me to go to the next slide to
Yes, ma'am.
yeah, go ahead. So what type of a granuloma is it? We can do the same thing, type of granuloma, type of giant cell, two things, and then take the differentials. Is that okay?
Yes, ma'am. It is a
Yes,
foreign body type of the giant cell, ma'am.
Yeah. And what type of granuloma?
Lymphohistiocyte.
Granulomas. So there were three basic types of host response. Don't mistake it. That is, it could be necrotizing, it could be suppurated, granulomatous, or lymphohistiocyte. Now here it is granulomatous.
Yes,
Now you
ma'am.
have different types of granulomas. You have necrotizing, you have non-necrotizing.
Ma'am, foreign body type of granuloma.
It's a foreign body. It's a non-necrotizing granuloma.
Non-necrotizing granuloma.
Yes. Now you go to your giant cells. What is your type of giant cell? You said was
It
foreign
is
body.
foreign type of giant cell.
Yes. But in addition, there was one other type of granuloma. Of course, sir just said. What do you think this is? Come on, what are these? They are large. Give a description. Bianca,
Cells.
Bianca, you want to try the cell type here? Help him out.
Chat, it is foamy.
It is for me.
Ma'am,
Yeah,
this
it's
is-
very good. So, like sir pointed out, the term is a misnomer. But what you're seeing here are sheets of these large xanthomatous cells, which are aggregating together. There are giant cells. And what is this type of giant cell you're seeing here? Yes.
Different type
And
of
this
giant
one,
cell.
Janki's already told.
Ma'am, it is foreign body type of giant cell.
Very good. So what we are looking at here are foreign body granulomas. There was also foci of, it's a combo. You have xanthogranuloma, you have foreign body granuloma, a lot of foreign body giant cells, and now come to the point. Yes, Janki, what do you think?
It is there is a acellular lamellated material, ma'am, throughout the slide, and it
Yeah.
is present in the left corner of the slide, ma'am.
This
And
one?
there is no there is scant or absent strobiles, ma'am.
Okay. So what's your diagnosis?
Alveolar echinococcus multiformis.
How do you say it's alveolar?
Alveolar hydatid.
No, how do we, so what are the types of hydatid?
Echinococcus granulosus and Echinococcus multiforme.
Very good. So how do we differentiate between histology?
Echinococcus granulosus has protostrobiles with lamellated acellular eosinophilic areas, ma'am. Whereas in case of Echinococcus multiforme, there will be scant or
I
absent.
think it's multilocularis.
Multilocularis, sorry, multilocularis.
Multiforme glioblastoma.
Huh?
Multiforme is glioblastomas.
Multilocularis, ma'am.
Yes. In that, you will not get the.
Strobiles, ma'am. Absent or decreased number of strobiles.
Can you, by strobili, you mean scoliosis?
Yes, ma'am.
So, Janki, can you still have it to be a echinococcus, but no scoliosis?
Yes, ma'am. In Echinococcus multilocularis, there will be less. There will not be scoliosis, ma'am.
Yeah, but in both of them, it may not be there in the sections that you got, isn't it?
Okay, okay.
In fact, people talk about sterile and fertile hydatid, right? So, looking at that, I at least I'm not aware that we can differentiate the two. We'll come to the differences. So, just to summarize, you said it's granulomatous and it's foreign body. And possibilities, do you want to? You already said. So, what do you want in this? You don't want anything at all?
We can do PAS.
Okay. Before that, this was what do you think this is? This was there in a portion of the slides. Anyone? Describe it. Priyanka.
In chat, it is suture, ma'am.
Very good. Exactly what it is. It's just what Dr. Sharma was just saying, isn't it? So all of this is actually suture. This patient had been operated previously, it recurred. So this is a recurrence of lesion. And you can see all of this is actually suture material. And you can see a foreign body giant cell response to it. But this is what Janki was pointing out, that you can see this laminated kind of structure. This is the GMS that we did. And this is a close-up view of that. So there is only one diagnosis. It's highlighted. And like Janki was saying, it has two parts. You have an ectocyst, which is what we were looking at. You also have the endocyst, which is a germinal layer, and that is what produces these protoscoleces. These protoscoleces, you can see, what are these? Janki, there are some linear structures which are kind of refractile. No?
Hooklets.
Hooklets, very good. Can you see the hooklets here?
Yes.
Can you tell me what the stain is? Anyone? It's so beautifully seen, that rows of hooklets. It's almost as though it's smiling at you, no? Anyone, what stain is this? Excellent, Priya. Yes,
ZN.
it is a ZN, it's a Ziel-Nielsen stain. So, in fact, if you have an aspirate from a hydrated and you want to look for these, you can just centrifuge it and make a wet mount. These will just stand out refractile. And if you do a ZN on that, these will just get beautifully highlighted. Excellent. So, very quickly, he has already told us there are two types. There is Echinococcus granulosus, which is a cystic one, which is what we most often see at the definitive host is dog. And you have the multilocularis, very less common, but it's more invasive. It's also called the alveolar Echinococcus. Not really endemic in India, though. I don't know how many of you have seen a case. We've not really seen a case. I don't know Dr. MC Sharma has seen a case. So the granulosis is what he described as this laminated hyaline ectocyst, and that is the protoscolesis. And outer to that is the pericyst, which will have the vascularized connective tissue. In the brain, remember that pericyst is very, very thin, and we hardly ever see it because there is no connective tissue. There's no collagen inside the brain. And this is the multilocularis, which will have, like he very nicely said, this grows out by budding, and that is why it will look like clusters of bunch of grapes. And this causes a very severe immune response. Even we thought that this was alveolar echinococcosis, but we realized that there is no way to differentiate the two. So we left it as echinococcosis. So what is the diagnosis on this? This is a spotter for you. Beautiful, picture perfect. This also is a scolex.
Cysty in group.
Very good. Yeah, so you can see the hooklets and the sucker so beautifully. Unlike hydrated, this will have a single scolex. And this is a brain. This patient died. Actually, it's a very old case, and this patient had been admitted in the psychiatry ward as diagnosed as dementia. And this was in the 70s when there was no imaging. And the patient had developed seizures and died of status epilepticus. This is what we saw. Every hole here is cirrhosis. Okay, within there, you can see some of them have this white spot, which is the milk spot of the scolex. So this is cystic cirrhosis. Okay, case number 3. This is a simple one. We can go fast. Who's case 3? Sharon.
Dr. MC Sharma sir wanted to add any points?
Yes.
Nothing, but I think radiology is important in the hydrated, no? To
Yes,
differentiate
very
the two.
important. Correct. So in fact, they had mistaken earlier cystic cirrhosis. This was actually labeled as a cystic glioma. Now we know that MRS, that is MR spectroscopy, is very useful. We have found a unique peak in hydrated. It's the alanine peak which goes up. So looking at that, our clinicians are diagnosing hydrated even before surgery. That's a very good point. Yes. Should we go to the next case?
Yes.
Sharon, all yours.
Case 3, it is a 21-year-old male presented with seizure, headache, and hemiparesis since 6 months. MRI shows a temporoparietal lesion, dura-based with perilesional edema. Clinical diagnosis of meningioma was given.
I've given you actually only HND. I've not given you the rest of it. So this is the very low magnification. So Sharon, very quickly, what is the tissue response?
Microglial proliferation can be seen with multinucleated giant cells.
You're saying microglia? See, microglia, if you look at, they are rod-shaped nuclei, and they're very, very tiny. But here, what you're looking at is a huge cluster. Come on, picture perfect. You can see something here. What are these?
With the multinucleated giant cells.
And then what are the small round blue? Those are lymphocytes, right?
Lymphocytes.
And what are these? Eosinophilic, they're kind of fusing together. They're fusing together. What are these cells? They have abundant eosinophilic cytoplasm. Priyanka wants to help her. Priyanka, what do you think this is?
I think it's the aggregation of lymphocytes, ma'am.
And
so basically, ma'am, it can be viral, ma'am.
Oh, but there are giant cells, no? It's actually a granuloma.
Granuloma is,
yeah, these are reticuloid cells clustering together. It is non-necrotizing. It's a beautiful, actually very discrete granuloma. There's a lot of fibrosis which is surrounding it. This is a close-up view of the center of the granuloma for you to tell me what the cell type is. You can see giant cells again here. These are, some of them are Langhans. This is a, what type of giant cell? It's a foreign body giant cell. And this is the back center of the granuloma.
Neutrophilic
So what kind of granuloma is it, ma'am?
Suppurative granuloma.
Suppurative granuloma. Very good. So the pattern you're looking at is a suppurative granuloma. So what are the possibilities if it is a suppurative granuloma?
Actinomycosis.
Very good. But also keep in mind fungal, TB. Third would be what you said. So what do you want for actinomycosis?
Actinomycosis. Fast stain.
Fast stain. Okay. What is specific for actinomycosis?
Gram stain. Gram stain.
What's the closest differential?
Sulfur granules we can.
Okay, this is the HND itself in one portion that we picked up. What are these?
Sulfur granules like
Yeah,
filamentous aggregate bacterial colonies.
Very good. So that's a close-up view. Actually, this is grams, but then we counter-state it with eosin. So those are your gram positive. And this is the GMS stain. Remember, GMS will pick up everything. It's silver. Okay, so it will pick up anything which has a negative charge. So don't be surprised that GMS is picking up. And this is the actual gram stain. Now do you see your bacilli? So this is the actinomycosis. It is very, very rare. We have not seen many cases, and we do know that it usually comes through hematogenous spread. It can also come through contiguous foci, either in your sinus or cervicofacial. The survivors usually have a lot of neurological sequelae. It's a gram positive. It is filamentous. It is non-acid fast, and that is one thing that is important to do. If this is not the 20% acid fast, you have to use what percent? To differentiate it from nocardia. It's a very close differential. Nocardia would show weak acid fastness, and that's usually 2 to 5%. So what we tell our technicians is do lepra stain. It's the simplest thing to do, right? Because that's 1%. So that is good enough. And remember that the infection is invariably polymicrobial. So in addition to this, you'll have a whole host of other bacterial species present, and that's very important for your actino because that is the one that is going to facilitate this actinomycosis to invade into the hosts. Okay, the response is like exactly what you saw, very characteristic, suppurative granulomas, and they do produce, like you said, draining sinus tracts, and what comes out is a sulfur granule, and that is what you should take for culture. They usually have intense fibrosis, like we saw in this particular case, and we do know that even when you culture these, unfortunately, in 50% of the time, it is culture negative. So it is your histopathology which will actually give the diagnosis. That's for several reasons, because you have a lot of polymicrobial infection. You have given previous antibiotic therapy. All right, so culture can be negative 50%. But important for you to pick those sulfur granules. But remember, those sinus tracts we may not see in the CNS unless the overlying bone is involved. So we are not lucky enough to be able to pick sulfur granules. And the characteristic feature is the splendor head flea phenomenon, which is very beautifully seen. So these are actually immune complexes being deposited along it, and that is being produced by your polymorphs which surround that entire column. So that's a picture of the splendor head flea phenomenon. So that's case 3. Any questions from the audience or
No questions.
anything? This is too classical. So you want to add anything?
Oh, I think very interesting.
We've only seen, I think, 12 cases so far for actinomycosis. And just one case of nocardia, because that was during the HIV epidemic. So shall we go to the last but one case? I'm sure you're not tired.
Yes.
So case 4 is, yes, Joshua, it's all yours. I know you chose case 5, but we're giving you case 4.
Joshua is muted, it seems. Can someone?
Joshua, will you unmute yourself?
Rishi ma'am, can you unmute him? So some other students can pick the case meanwhile.
Yeah, Priyanka, you want to start?
Case number 4 is a 32-year-old male presented with sudden onset of fever, seizures, and altered sensorium. He had a renal transplant 1 year prior. An MRI showed multiple hemorrhagic lesions involving bilateral, frontal, and temporal white matter as well as cerebellum. And he succumbed within 2 weeks of admission, and sections from the frontal lesion are provided for opinion.
Okay, so Priyanka, you just want to tell me clinically what you think when there's fever, seizures, altered sensorium?
Ma'am, there is a focal deficit is there, ma'am.
Very good. Okay.
And secondly, ma'am, since he had a renal transplant, so the patient is probably immunocompromised.
Excellent. So what infections do you think you would like to consider in a renal transplant recipient?
Fungal.
Very good. So that's what even the clinician thought. And this is what the autopsy shows. I'm just showing you one slice. So this is the frontal. And can you see one huge lesion out here, which is, what's the color? I know pathology is full of color, and the color actually gives away the diagnosis here. So it's open to the house to tell me. Yeah, I think from the house, they've also said JC and CMV. Yeah, CMV is a good possibility, very good. But it's brown-black, okay, color is brown-black.
Brown-black.
Any other?
In chat, it is
lovely habit of saying gray for everything. Even if it's blood red, they'll say it's gray.
Very good.
Yes.
Joshua's back.
Joshua's back in action. He wants case 5, we'll give him case 5. And Joshua, yes, you can add. We're discussing what the color of this lesion is.
In chat, it is brown-black, ma'am.
Brown and black. Okay. Brown and black. Fair. We'll come back to the color. Remind me, otherwise I'll forget. So this is what the pathology showed. So this is just to orient you. See, this is the brain parenchyma. Okay. And this is the lesion proper. And Joshua, what do you think? What is the lesion showing?
Showing on the right side, the lesion that appears necro-inflammatory.
Very good.
And then on the right side, you have the brain parenchyma with prominent vessels that appear thrombosed.
I wouldn't say they're thrombosed. In fact, I
Okay.
think there are RBCs
Okay.
which are coming out. isn't it?
Yes.
What do you want to call it?
Mm.
Hemorrhages?
Yes,
Small
vesical
hemorrhages, so you want to give it a name?
ring hemorrhages.
We would call these punctate hemorrhages.
Punctate.
Okay? Punctate.
Yes, punctate. Yes.
And this you said is necro-inflammatory. And there is
Yes.
also a lot of blood here, isn't it?
So hemorrhagic necrosis.
Very good. Agree. Shall I go to the next picture? So you mentioned that some of those vessels have. So this is what maybe you were referring to.
Yes,
So
ma'am.
within those large areas of necrosis, there is fibrin thrombi. I agree with that. And what are you
Yes.
seeing here?
These are-
Macrophages.
Correct. And this kind of macrophages, no, which have this kind of foamy, kind of tightly vacuolated cytoplasm, we use the term jitter cells. They got that term because in a CSF, if you're looking at it under a microscope and the light of the microscope falls on this, they glitter. They glitter because they are filled with lipidic material, which are kind of refractile. So that's why it got the term jitters. It's like looking at petrol when you shine light on it, right? That kind of thing. So these are jitters. So what do you think? Joshua, you said necro-inflammatory with hemorrhage, with fibrin thrombi in blood vessels, and the predominant cell type you're looking at are these kind of foamy macrophages, or if you want to say jitters. So what's your preference?
I was thinking likely to be viral. I was thinking initially the HSC virus infection.
HSV, you said?
JC virus.
JC virus. Okay. So I think many of you have said viral. So I'll just take a short, we'll stop to talk about viral before going forward. Now, viruses, remember, the most common pathology that it produces in the brain is just a plain lymphohistiocytic pattern. Necrosis, hemorrhage, very, very unusual, with the exception of one family of viruses, and that is the herpes group. So HSV, varicella zoster, and CMV. These are the only three viruses, okay? Only three that you should remember, which can produce hemorrhagic necrosis. Having said that, the location of this lesion will be very easy to help you diagnose which virus. For instance, if you have hemorrhagic necrosis around the ventricle, as in a necrotizing ependymitis, it is CMV. If you have hemorrhagic necrosis in the medial temporal lobes, it is herpes simplex. Varicella zoster is a little more challenging, and you'll get, it can be like this, where you have multifocal hemorrhagic lesions throughout the brain because it produces a vasculitis. Is that clear? So these three like endothelial cells, they like macrophages, and that is why they produce hemorrhagic necrosis. Now, here, what you had was, it was not involving the medial temporal. It's not herpes. I won't completely exclude zoster. We can think of it, particularly because he's immune compromised. CMV, very unlikely, because this kind of hemorrhagic multifocal lesions throughout the brain involving frontal, cerebellum, very, very rare. Even in the HIV epidemic, we didn't see this kind of disseminate. It was usually an ependymitis. Okay, so I would put viral very low down on the list. Now, JCBK that I think some of you put up on the chat. Remember, BK doesn't like to involve the brain. It likes the kidney, doesn't like the brain. There are only case reports of BK virus causing a meningitis in the brain. Most common in that family is the JC virus. JC virus can involve the brain, and JC virus likes oligodendrocytes. Okay, so viral infection is very, very simple. If you know which cell type the virus likes, you can predict what the pathology is. Now, you tell JC virus, I'm telling you, likes oligodendrocytes. So, which part of the brain will it go to? Where do you find oligodendrocytes?
The white matter.
Absolutely. So this will involve only white matter, and it knocks off the oligodendrocyte. It's a lytic infection.